Welcome everyone to the Society of Thoracic Surgeons Congenital Heart Surgery Database new Data Manager webinar. Today is September 14th, 2021. So thank you everyone for joining today. First of all, I want to welcome everyone on the call today. Let's see here. From the STS team, we have myself, Carol Crone, Addie Dolan, Emily Conrad, and Sydney Clinton. And we also have from our core group side and CHSD consultant, we have Chastity Wellness, and then we also have Leslie Wacker joining us today. I don't think we have anyone from the IQVIA team on today, but the IQVIA team does typically join. For those of you new to the congenital webinars, the IQVIA team does join our user group calls as well as our monthly webinars. So for our agenda today, let's quickly review. I'll touch on some, just did the welcome and introductions, and the next I'll do an introduction to the STS and the databases, and then I'll turn things over to Leslie for a portion of the presentation. She'll go over the role of the data manager, how to read the data collection form, required fields, data specs, and then also Chastity will be wrapping up the presentation. She'll be covering the latter part, intro to training manual, submitting a question. We'll go over keys to abstracting data, building a relationship with your surgeon, ensuring clean data, a review of data submission deadlines, and then a review of additional STS resources that are available to you all. So I'm pretty sure that's when they're going to take over, but just I may have missed, not gotten that completely 100% straight, but Chastity and Leslie will be taking over the rest of the presentation. Just a quick introduction to your STS National Database team. We have Donna McDonald, and Donna is our fearless leader. She is the Vice President of Quality. Next, we have Jane Hahn. She is our Associate Director of Quality, followed by Carol Crone, Senior Clinical Manager for the STS National Databases, and that is for all the databases, adult, congenital, and general thoracic. Catherine Holyfield is our National Database Manager for Intermax. And myself, I am the National Database Manager for the General Thoracic Database and the Congenital Database. Next, we have Emily Conrad. She is our STS National Database and Patient Safety Manager. You all will be hearing more from Emily. Emily, so you guys hear from Emily throughout the other presentations. She is in charge of our AQO. So she is very busy right now with lots of making us all stay on track and getting our AQO presentations in. We have Derek Stack. He is our STS National Database Contract Manager. So if you have any questions regarding your contracts or participation agreements, Derek is the staff person that you work with there. And Addie Dolan, she is our Senior Coordinator for the STS National Database. And then we have Leslie Wacker, our core group member from the University of Michigan, presenting today. And we have Chastity Wellness, our core group CHSD consultant from Phoenix Children's. Also on the call today, and I apologize, we do not have Sydney's picture up here, but I will get it added prior to posting these slides online. We have Sydney Clinton, and Sydney is our public reporting staff person. Sydney handles all of the public reporting for STS as well as TQI. So thank you, Sydney, for joining. And I apologize, I don't have your picture up here, but I will get it added prior to posting all of these slides. All right, so I want to give a brief introduction to STS and the national databases, just some background information. So the Society of Thoracic Surgeons was founded in 1964, and our mission is to enhance the ability of cardiothoracic surgeons to provide the highest quality care through education, research, and advocacy. Currently, we have more than 7,500 members in 99 countries. The STS, our main headquarters, is in Chicago, and we have a second headquarters in DC. We have more than 65 employees. So we're not one of the larger societies. We are one of the smaller in terms of employees. So again, we have more than 65, but based in Chicago and DC, and myself, who is actually in North Carolina, and Catherine, who is actually, she is down in Alabama. So we do have a small group based, in comparison to other medical societies. So the first database was started in 1989 in response to Health and Human Services, Healthcare Finance Administration, which we all know now and refer to as CMS. These databases were started in response to malpractice lawsuits that were related to misperception on the risk associated with surgery. Also, the Joint Commission on Accreditation on Healthcare Organizations requirement of health systems to have a quality assurance program used for surgeon recredentialing. And also this the databases were created in response to threats to reimbursement for surgeons. Some of our database accomplishments from the STS, we have had improved patient outcomes and patient safety. We've developed clinical practice guidelines, such as a couple examples of blood conservation and antibiotic usage, and also the voluntary public reporting. So we do have sites who publicly report their data that, sites who publicly report tend to have better outcomes. And we'll have more information here on publicly reporting. Also, the Congenital Heart Surgery Database was commenced in 2003. As of July, our current statistics, as of, I believe, July of this year, we currently have 118 total sites. Of those 118 sites, 117 are North American, one international site in Saudi Arabia. We currently have 67 anesthesia participants. Of those 118 total sites, 425 participating surgeons. We have 667 anesthesiologists in the congenital database, and the congenital database currently has over 590,000 procedures for over 361,000 patients. So of our 118 total sites, we have 90.6% of our congenital sites currently participate in public reporting. So that is an amazing amount, that high percentage. That's amazing, and we love to see that. Before I turn things over to Leslie for her portion of the presentation, the data abstractor data manager, we do have a couple of polling questions that I wanted to launch to get some, just to get some information from you guys to see what your backgrounds are like. So I'm going to go ahead and launch these polls. So let me go ahead and do this to relaunch the poll. All right, so you all should see the poll. Carol, do you guys see the poll?
Yep, it's up.
Okay, perfect. So our first question, just a couple of brief questions. How long have you been extracting? Less than 6 months, more than 6 months? Our second question, do you have clinical experience? Simply a yes or no. And then our third question, again, yes or no, do you abstract for any other databases? So I'll let this run for a second. Let's see here, we have about 62 people in the webinar. Looks like half are answering the questions. So I'll let this run for just a little while longer. Let's see here.
Leanne, will you let that run? I just want to expand a little bit about what you said about the reason why the databases were started. In response, yes, this is Carol, in response to HHS and HCFA, HHS and HCFA put out outcomes of cardiovascular surgery using claims data, which was not risk adjusted. And so it really wasn't, so you saw a lot of really bad outcomes, but they weren't taking into consideration the risks of the patients when they entered the OR. So it showed really bad outcomes, and that was leading to various issues, including malpractice lawsuits, decrease in reimbursement, and things like that, because the government doesn't want to pay for things that aren't helping patients. So in response to that, the surgeon leadership of STS at that time in the late 80s got together and decided that we needed to really address these questions. So they said, we have to show them. We can't answer. We can't say that they're wrong without showing them data that they are wrong, that they're wrong in assuming that heart surgery is leading to bad outcomes. So we developed the database in hopes of developing risk models, which then makes the comparison of patients a little bit more equal across the board when you look at their expected outcomes compared to their observed outcomes. So you look at the expected outcomes of taking all their risks into account, the patient's risks into account, and what are we thinking is going to happen? What are we expecting going to happen versus what really does happen to those patients? So the major thing there with the start of the database in the early 90s, late 80s, early 90s was to form risk models, which we now have for all three of our databases. So I just wanted to add that in while folks were still voting. Okay, thank you.
No, that's great. That's great background, Carol. I appreciate it very much. You have a lot more of that background than I do, so I appreciate that.
Just dazzling what you said, Leanne.
So I did share the results of the poll. So just going to touch on this real quick. So it looks like more about 24% of us have less than 6 months of experience abstracting, and we are about 9% more than 6 months, less than a year. 33% of us have about 2 to 5 years. So that's good to see, and about 13, 5 to 10. And then we have 9% have 10 or more years. So we have a wide variety of experience here with us today. Clinical experience looks like a majority of you, 91% of you do have clinical experience. So that's good. And also, let's see here, do you abstract for other databases? So it looks like we're about split. We have about 54% that do abstract for other databases, and we're about 46% that do not just abstract strictly for congenital. So thank you guys for responding to the poll. Greatly appreciate it. I'm going to stop sharing the poll results, and then I'm going to turn things over to Leslie Wacker for her portion of the presentation. Leslie?
Great, thanks, Leanne. So in addition to getting that little bit of background about the people on the call today, we know from chatting with you all on multiple occasions that we're a collective group of smart and creative and the good kind of passionate person. Many of us come from a nursing background, some have other health management roles within our hospital, but in some way, no matter what, we're all making a huge difference in the world of congenital heart surgery. Next slide. We also have quite a bit of difference just across the board. What a data abstractor is or a data manager is at each hospital kind of varies. So site to site, your role might look a little bit different. You might have a large or a small team, but in general, we're responsible for this sort of range of responsibilities. Abstracting data from the medical record and submitting it to STS is obviously kind of forefront. We also clean the data and then resubmit using our IQVIA platform tools. Many of us also use our STS data in QI projects on site. These can be we can use these to help develop best practices or standard operating procedures. This can translate into improving workflows and team dynamics at our sites. Many site managers also review the data or participate in meetings with their surgeons and other supporting departments. And then many of us analyze data to our administration teams. Next slide. Thank you. Okay, so we're going to review the data collection form. This can be found on the STS website. So starting at the very top, you'll see the version number. This one's version 3.41. These update on average every 3 years. And then directly under that, you'll see the updated date. So sometimes there's revisions within the data collection form after it's published. And so you'll see that date there at the top. Right in the middle, you'll see a highlighted section in yellow, and this represents a change from the previous form. The kind of pinkish red title bars, I would say, are the different section names. So this helps when we reference data and where the data is stored. So you might hear on our calls, that's a field stored in the demographics table or in the operations table. And this can affect which fields are saved case to case, or which you might have to enter individually for each surgical event. The section is also referenced in the specs document, which we'll get into in a little bit. And in addition, if you pull data at your own site, knowing the section will make identifying the correct tables or kind of where the field lives a little bit easier when you're creating data queries. And then under each section name is the field name, that's in black. So at the top, you'll see participant ID. Just under that in red will be the short name and the sequence number. And these are important to know, and you will be asked for these in items when you fill out an FAQ or submit a clinical question. It also makes searching the specs document and the training manual a little bit easier. So it's really important to know your short name and your sequence number. So it seems like a lot having a few different names for each field, but because some of these have very similar names, it helps create consistency over time and make sure that we're referencing the correct field when we're talking about them. Next slide. Okay, so which fields do you need to complete? So the simple answer is all of them. Per STS, all of the variables are important and we really want all of them complete, but some fields will actually affect your ability to submit your data and get analytic reports. So for sure, you do not want to skip or omit fields that are reported in analysis. And those would be in your mortality reports, case mix models, benchmark operations, and the lesion-specific tables. It's important to capture fields consistently at your own site so that it remains meaningful internally and over time. It's a great idea to develop an abstraction tool or a set of guidelines within your institution, which will help identify where you're getting each field or that piece of data. This will help you when your site is audited, but it also helps your team, should it be more than you or if you move on to a different role, just remain consistent over time. Next slide. Okay, so the data specs, data and software specifications. This is one of the kind of companion pieces for entering or collecting your data. You will refer to this very often for a definition. It's the full definitions manual. It updates along with the data collection form every 3 years. Here you'll find the full definition for each field, the allowable values, the type of field or kind of what type of information the field is expecting, whether it's numerical or text, and then any associated parent and child relationships. The data specs are also used by our vendors to help build their product. Many experienced data managers, and I would certainly recommend keeping this open at all times when you're abstracting data. Next slide. The other companion piece to keep open along with your data specs would be the training manual. This document updates monthly, so I don't recommend you bookmark the actual PDF, but rather save its location. So that way when you open it, you're getting the most up-to-date version. You'll want to reference this pretty often as well for any updates or clarifications that have been made to the fields. You'll see the most recent updates in red. And then this is a good way to sort of familiarize yourself maybe over the length of the version over those 3 years, how it might have not changed necessarily, but kind of how we're interpreting it. So look here before you submit your FAQ to see if someone else has had the same question. Very many times we all have the same questions. And then this will give you a little bit more context. Okay, next slide. So as I mentioned in the specs, you'll also see what we call allowable values. So many fields have expected and allowable values that are associated with them. Here's an example of hemoglobin. So your vendor software should warn you if you've entered a value that is not expected. So in the graphic here in green, that would be kind of the expected range. We think it's going to be within that green range, but the yellow would be our allowable range. So you'll get a warning that it's not expected. It gives you a chance to double check that what you've entered is correct. And then you can still choose to accept that option. That's a little different than the allowable versus not allowable values. The software will not accept some values which are significantly out of range. So in these cases, your software will not allow you to submit the value at all. So if you see that error and you're absolutely sure that your data is correct, you would enter the lowest or the highest allowable value. So in this example, if your hemoglobin truly was 2.5, but the lowest allowable value is 3.0, you would enter 3.0. And that just helps to ensure that we're not getting completely erroneous bad data. We're keeping it a little bit tighter, and we're also providing you warnings to make sure that what you're entering is correct. Okay, next slide. Okay, so if you've gone through the specs and you've checked the training manual, but you still have a question you can't find the answer to, you can enter an FAQ or a clinical question, and that's available on the STS website. To do this, you will need to know your participant ID number, the short name, and the sequence number of the field. So we talked about that a little bit earlier. And then we would like you to provide as much information as you can about the situation without giving us PHI, so that we can kind of review as a group and weigh in. Okay, next slide. So once you've hit submit on your FAQ, that will be compiled into a list for our monthly core group calls with our surgeon leaders. So in the process of doing this, we review previous FAQs, we look over the specs in the training manual, and then we all come together as a group and discuss the questions. Sometimes we do have to triage these questions to IQVIA or DCRI if it's a sort of analytic question, or to anesthesia, and they don't always join our calls. Or sometimes we just have to loop in additional surgeon experts or people who have been a part of this a lot longer than we have, maybe. We spend a lot of time on the questions. Very often we go over our hour on the call and sometimes even schedule additional calls to wrap up or kind of discuss further via email, getting everybody on the same page. But we're striving to remain consistent over time. All of that means, however, that you might submit a question and not hear back from us for what seems like a very long time. We aim to get these back within the month, but obviously if you submit a question just after we've had a core call, it may be up to a month before you receive an answer. That answer will also be published in the training manual for all data managers to reference. So even though it seems like it takes a while, this process really is superior and works out better than trying to answer kind of off the cuff on our webinars. We want to make sure that as many people as possible have a chance to weigh in and that we have plenty of time to review previous answers and the training manual. Okay, and now I'll turn it over to Chastity.
Great, thank you, Leslie. So I'm going to start with what are the keys to data abstraction? What is your approach when you start looking in your electronic health records and try to abstract this data and put it into the database? So the biggest thing that I can tell you is being organized is critical to your success. Just remember that all data managers perform their duties differently, and this is really dependent on the hospitals in which they work or the institutions in which they work. But we're all after a common goal, and that is really to collect the entire data set with complete and very accurate information so that we can compare to one another, but also advance the care of the children with congenital heart disease. So where do we get our data? It may be very different depending on where you work or what your setup is at your work. So people may have complete electronic health records, and other people may still be working off paper or have a hybrid type chart. So the point is you have to know your system and work within that system and come up with methods and ways for you to collect your data accurately. So no one can tell you, I get my information here and you might get your information from somewhere else. So you just have to figure out where those standards are in your system to find specific pieces of information. So I would refer to this as kind of the gold standard. Where do you go to find the extubation time? Where do you go to find the time the OR starts for the patient or when they wheel into the OR? So that's going to be different in your institution from my institution from Leslie's institution. But you've got to figure out what your gold standard is. And you always want to go back to that gold standard for that field, that no matter what, I find the OR time here. You don't look for it in a different place with every patient chart. So you want to consistently go back to your gold standard, and your gold standard is going to be different than my gold standard. And so just finding those. And so I often go through the exercise with new data managers to say, go through the entire data collection form and figure out your gold standards. They may change over time, but be consistent. And if you ever change what your gold standard source is, that you're documenting that so you know when you made that change. You also want to pay attention to source documentation. So source documentation, in my mind, is your source of truth. So I often say that this is, a document that was written by the person who did the intervention, i.e. maybe the surgeon, maybe they are the intensivist or cardiologist who made a certain diagnosis, or maybe they were the person that treated the event that occurred. Those are your source documents. And so you want to always refer to the source documents wherever you can. So while I know when a patient comes out of the OR, my intensivist will write a really beautiful note saying the surgeons did this, 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 and that. And I very easily could go into my database and say, well, they closed a VSD and they did this to the ASD and whatever. However, what I really want to do is go to the source. So who actually closed those lesions in the heart. It was the surgeon. So I want to wait for that surgeon note to get dictated. And that is my source of truth. That is my documentation. And I'm not saying that the intensivist got it wrong or that they don't know what happened, but the details of your repair or of your procedure are going to be in that surgeon note. Another place that I think source documentation is incredibly important is birth records. So we've probably all seen over time that, starting in your EHR, where maybe perhaps a child was not born within your health system, this was their birth weight and this is their gestational age. And as you go through the chart, numbers get rounded and things. And next thing you know, they're no longer premature in the documentation or have a completely different birth weight. So if you have source documents, if birth records actually get scanned into your system, you want to go as close to the source as you can. And if you don't have that, then perhaps it's their initial encounter, with your institution to get the birth information as close to that birth as possible. And so you're always looking for source documentation. You also want to pay attention to your data specs or the training manual. And you want to make sure that you are utilizing the definitions and that your data is meeting the field requirements. So there may be timeframes associated with a certain field within 24 hours of the date and time of surgery, during this hospitalization. Those have really severe meaning and allow us to level the playing field, that if I'm saying a patient received mechanical ventilatory support during this hospital admission, it means the same thing at my hospital as it means at Leslie's hospital. There also could be specific lab values. And so if you don't meet those thresholds that are specified in the definition, then your patient doesn't meet the criteria in the STS database. So sometimes an example of this can be in your charts, you see clinicians writing things like renal dysfunction. I'm not arguing that the patient doesn't have a degree of renal dysfunction, but if they don't meet the specified definition as laid out in your training manual or in your data specs, then in the STS database, we don't select renal dysfunction. And so you have to be really looking at that training manual and keeping it open, as Leslie referred to, at all times. We can't memorize every lab for every preoperative factor or for every facet in the database. If you can't find a data point, ask your surgeon or another clinician. I would say I lean heavily on my cardiac intensivists and my surgeons to clarify things, or if there's something I can't find, or perhaps something wasn't documented very well. The best thing I can say here is do not guess at a data field. Don't make an assumption like, well, I know the nurses upstairs would always do this, and so therefore I'm going to chart this or that. No data is better than bad data. And if you find people aren't documenting something consistently, this is where you go back and work with your clinical teams and say, hey, I can't ascertain this or that because the documentation's a little squirrely. And oftentimes these are great projects for nurses, and they very much appreciate that what they are documenting is meaningful and is being utilized in another way. So I found that when you partner with, ICU nurses and things or even the OR, that they're very receptive to this and just, are really interested in this data and how your center is performing. Next slide. So working with your surgeons, sometimes people find that this can be an incredibly challenging component of their role as a data manager. And I know sometimes this is very personality dependent, personality of your surgeons, maybe your personality. And so I think the biggest thing here that I can say is their job is to operate. They don't know all the ins and outs of the STS database definitions. And Leslie and I have a statement. It's why you pay me. So I know the ins and outs of the definitions, or I at least know where to find them. And I have my manuals open at all times to refer to. And so I think together, you and your surgeon can identify some, maybe I don't know where the path of blood is going, and I need him to tell me what he baffled or what he patched and where the blood is going in this heart now, so I can fit it in the boxes of the STS database. But I just remember, like, if you go to them and say, what's the primary procedure? They don't know the rules. They're not reading that document with I don't know how many rules there are now for determining that, but there are quite a few rules. That's not what they do, nor is it what they do well, right? They operate. And so it's, know it well, you bring the definitions and, help me fit this in the box is kind of more the conversations. You also want to get involved in any hospital or departmental level meetings where your data is being discussed. And so I think think the best way to do this is jump in and start presenting data. And for anyone who might be scared to just jump in and give a presentation, maybe start with putting some slides together, getting the data together, and allowing perhaps your surgeon or departmental heads to present the data initially. But I think the more you see how the data is utilized, the better you are at collecting the data. When you can speak to how it's reported out, you know exactly how it goes in as well, and you become that content expert. Sometimes it's really helpful to ask your surgeons if you can observe a case. I think there's a lot to be learned in the OR. I'm never going to be able to, close any hole in the heart at all, but it's kind of fun to be in the OR and see how it actually all goes and all the jobs of, the people down there. I'm not by trade an OR nurse. And so I have no idea about that black hole. And so it was fun to go in there and kind of see, how it all flows and how it goes. And it gives me an idea when I'm collecting data points from the OR, what goes on or who to ask, like who really knows what's going on in there. And it's probably not the surgeon because again, their head is down in the surgical field. And so it's learning who that cardiac OR team is and working with them. Also, make suggestions. You want to review your data with the surgeon. I don't think it's ever a good idea to be disconnected from your surgical team and that you sit in a vacuum and collect data. And then a few months down the road, you give them their analysis reports. I think when you're regularly reviewing your data with your surgeons, it's very helpful, not only to you, but to them as well. They always know how they're performing. Nothing is a surprise then when the data report comes out. And so you kind of get in a groove with what is necessary to review with your surgeons. Mine like to review the major complications and mortalities. Those are the big things near and dear to your heart. They like all the other detail that I bring to meetings and things, but if there is something, in a hurry that we need to get to, it's always the major complications and the mortalities. And it's funny when you collate the data and bring it to them and say, we've had X number of strokes, let's say, and they say, no way, we haven't had that many. And then we can drill down into, the specified number of patients who've had strokes and review them. And sometimes they're like, wait, does the definition really say that? And other times they're like, wow, I didn't realize all of these occurred in a certain specified amount of time. When the data report comes out and some of those complications are reported in that analysis report, there are no surprises and they're not coming after me saying, I think our data is all wrong and things. They know what their data is going to look like. And it, when you're constantly working with your surgeon, I think there's room for, less surprises. You also aren't waiting for the analysis report to come back when you know your local data, and that you can start implementing things and making suggestions. Hey, I'm seeing that I'm checking that box of wound infection more often than I'd like to be checking that box. How are we doing? Is there something we need to look at? Is it home care? Is it ICU care? Is it OR care? Is it prep work for the skin? And so you can start seeing this in the data and partnering with people around the hospital. Also, I think documentation is huge. You see all of the documentation errors or missteps in the electronic charting. And so my data team has worked really closely with the ICU nurses to say, sometimes this copy and paste function doesn't work really well for you. And you extubated the kid 6 hours earlier, and yet you still continue to check, that they're intubated in the EHR. And so sometimes like our real-time data checks serve as a really great feedback to them. They're busy, they're caring for patients, they're keeping people alive, and they don't realize that they're making these documentation errors. And so it's nice to go back to the staff and say, these things matter. And they usually are really, really receptive to our feedback. And so again, partnering with staff, I'm really talking about the OR, the ICU, the intensivists, and cardiology. I think they're all your friends, and they all like this data. They all want to use this data. STS has really been the gold standard in cardiac databases. And so people love to use this data for research and for all kinds of other things. So the more you, I think, make yourself visible within your departments, the better you will be and more successful you'll be. Next slide. Clean data. The biggest thing that we can do as data managers is provide incredibly accurate data. And so part of our jobs after we enter our data is to validate that our data is correct or clean. We want to make sure that when those analysis reports come back and they compare my center to the aggregate STS, that I have the most valid data. Because the worst thing would be is to come back to my surgeons and say, well, take this with a grain of salt. I think I made some mistakes. I'm not very good at this. That's not good for anybody. It's not good for the database as a whole when other people are comparing themselves to your program in those aggregate numbers, but it's also locally very problematic. So there are different methods for doing this. So many of our vendor softwares have mechanisms that can identify data entry errors or have some type of error reports that you can run. So I suggest that you work with your vendors or perhaps partner with other data managers who use the same vendor software as you and find out what they're doing or what kind of things they're running. I know just within my software, I have a few things, but I also have my own reports that I run and can, queries and things that I look at to make sure that dates and times make sense, to make sure I don't have any missing fields, to make sure that if I select this complication, there's obviously another complication that goes with that. And so before every data harvest or data submission cycle, I'm running all of these reports. IQVIA, our new reporting platform, is also a place that has some tools and reports that identifies missing data. There's the primary procedure mismatch report, and also other data errors, critical errors and warnings and things that you can look at the time of when we're submitting our data. We also can continuously harvest, so we can send new data to IQVIA at all times. Even if it's not a part of the current analysis cycle, you can be submitting last week's cases if you want to. And then that way you can clean up as you go. So some of us like to wait because we've been doing this a long time and we used to have to wait. And so many of us might do this right before harvest closes. Others of us do this as we go along and every 3 weeks or something, have some type of specified time frame that we submit data to IQVIA. The whole point is be consistent and you know your approach. And as long as you are organized and you come up with how you're going to do this, you'll be fine. And so just, try to figure out what works for you and in your workflow. Next slide. So we always need to be aware of our data submission deadlines. So in general, we're a little off cycle right now, but in general, data submission is 2 times per year in the congenital database. And so that's in the spring and in the fall. And we will get risk adjusted reports on the IQVIA dashboard available to us following the close of harvest. And so I always said that I live by my child's school calendar and the STS data submission calendar. Like that was my life. Like everything got planned around STS and school. And so I, get these on your calendar ahead of time. They're often, announced early, so we always can anticipate. Now, I will say that we are off cycle. So we are making the announcements are on the STS website. And of course, in webinars like this, or in our monthly data manager webinars and user group calls, these announcements are being made as to when we think this current harvest cycle will end, when the new data reports will come out, and when the next one is going to begin, when your next data deadline is due. So always pay attention to those and write those down. I put them on a whiteboard, I hang them all over my house, so I always know when my data is due. Next. Okay, so there's some additional STS resources out there for you. So as I mentioned, we do have monthly didactic webinars, and these get posted monthly out there on the STS website under the database webinars, and you scroll down to congenital and you'll see. And so you knew this one today, and that's where you find the link to the meeting there as well. I have a placeholder on my calendar so that every month at Tuesday at 9 a.m., I go look at the STS website to see when those are being posted, and so that I always then have them on my calendar. The monthly webinars, we often will have an educational topic to discuss. I do most of those educational topics, as does Leslie. And what we like is serving on the core group. We get a lot of questions every month, and some are very similar in theme and content. And so we use those to guide our educational topics. That being said, that's not the end all be all. If you have questions or you have an idea that you think, hey, I've talked to other data managers, especially new data managers, and they have these ideas, send me an email, send Leslie an email, send anyone at STS an email, and it'll get back to us and we can plan a webinar. They're for you. And so we want you to get the most out of them and, start giving you the information that you're looking for. Also, we have the monthly user group calls. And so these have the same feel as the webinars, and you'll see the same topics discussed initially, some STS updates, as well as IQVIA updates, which also happen in the monthly webinar calls. But this is a time where we use the chat function or the Q&A function to allow the participants to ask questions. What we do ask is that these are more operational questions in nature. Hey, does anyone have any ideas as to how they can collect the 30-day follow-up on patients? Does anybody do this or that? Or how will the data be used? What will we do with the COVID positive patients? Those kinds of questions are the things we want to answer in that call. Dates of closing harvest and those kinds of things. We don't want you to ask clinical questions. And I think Leslie went into, a really great information on that on the fly, off the cuff answers are not a good idea. We could not be thinking, I think, of the question as a whole, or how it could impact, how our answer could impact other answers, how our answer could impact analysis. And so when we're all together in a group and can hash it out, it's funny how the most simple question turns into a 20-minute discussion on the core group call with 3 surgeons and multiple core group members, trying to get you the most consistent, best answer. And it also gives us an idea to say, you know what, we need to look at this for the next upgrade. Who would have thought this scenario could come up, but it's a real scenario. And so it allows us to really think through that. And so we don't want to answer your clinical questions on those calls. We also have then the new data manager webinars, which you're on one right now. So you found your way here and understand that this is a resource. Also, we have what's coming up is our AQO meeting. It is a meeting that is specifically for STS database managers. And so it's lovely. There's not a, surgeons go over here and do this and clinicians go over there and do that. This is a meeting for us as data managers. And I think it's a really well run meeting. And I always enjoyed it. Even before I was on planning committees and things, I really enjoyed the content and the variety of content and being able to network with people. I know right now it's virtual, but I think that once we go back in person, which I know may be coming as soon as next year, that you'll really see the benefit of attending, and not only for the content, but just for meeting the other people who do what you do. And many of us have become friends over time, and it's really great to find those people. Next slide. So this is a little bit more about AQO. And so the dates are October 12th through 15th. You're welcome to attend any and all of those dates. However, the 15th is specifically for the congenital database. So that's really where you want to attend. It is free for anyone who is affiliated with their site's congenital database. And so get on and register. It's all available through the STS website. And if you need help, contact any one of us or anyone at STS, and we'll help you walk through that. Leslie will be the good old MC, and she is fun and high energy as she gets us through the day. And so I think a virtual format is the best we can do right now. And last year went really, really well. And so I was really impressed with this conference. And so I think that you'll have a good time too. And there's so much to be learned. All right, next slide. I think that's it. So please, we want to hear from you, and we want to get through as many questions that you might have as possible. And so please use the Q&A function, and we'll read the questions out loud and give you the best answers that we can, or help you get to the right place.
Great. Perfect. It looks like we do have one question from Sarah. Did you want to read the question, Chastity, or do you?
Oh, I sure can. Yes. Are there
you.
suggested data validation checks anywhere on the website? If we do not have a partner facility, it would be nice to have ideas of possible data cleaning opportunities. Okay, Sarah, there's not any, I think, that are available on the website. However, I did a presentation at AQO last year. Leanne or Carol, do we know, can people get to those presentations?
They're not, I don't think the AQO presentations from last year are available, but if Sarah reaches out to either you or I, we can, we can share your presentation with her.
Okay, perfect. Sarah, I'm happy if you send me an email, I can give you my slides. And then that way you can see. I went through and gave a presentation on how to validate your data, and gave all kinds of ideas of, different things that I do personally within my data. And so I'd be so happy to share my slides with you. So me or Leanne can send them. Either way is fine.
And I wanted to add something onto that, Chastity. There is the, I don't know if this will be helpful or not, but on the IQVIA platform under the library, we have our errors and warnings reference list. So I'd be happy to show, go
right ahead. Absolutely.
Can I show, I'll show you all where that's at, if that's okay. Okay. So I just logged into, this is Carol speaking. I logged into the IQVIA platform, and under library on the left-hand side here, These are all of our resources that we have, and this errors and warnings reference list, it'll download as an Excel file, and it's up to date, version 3.41. It's just going to take a second to open. Hopefully it opens, and it has the logic in here, which is, let's see if that's going to work. There we go. So this, and it goes back a couple versions, 3.3 and 3.41. I know that's really small. But for example, the 3.41 warnings, and there'll probably be more added with the new version when the new version goes live. But just for an example, can you see my screen? Okay, is that big enough?
Yeah.
Yes.
If, for example, status at 365, so a year after surgery should be entered since mortality 30-day status is alive, please review. So it kind of gives you the check that IQVIA is putting in place when the data is uploaded. And then it also gives you the logic, so you know which fields are being looked at to come up with this warning, and it makes it really easy to check these fields. Other ones, like if we're looking at errors, this is quite a longer list. This is more logical information, so we'll look at line 5 here where it says date of birth. This says date of birth cannot be later than current date, which means that today is September 14th, 2021. And I accidentally, my fingers accidentally went too fast, and I typed in the birth date of September 1st, but I put 2022 in there for some reason. And so this error is going to fire, and it's going to say my date of birth is greater than today's date, and that's wrong. So I know which 2 fields to look at, and then I can go and easily check my data. So this might be helpful too to have downloaded. And there's other things in here when you look at values and different ranges. This is where you're going to find those. So this is probably a pretty helpful document as well.
Mhm.
Okay, I'm going to stop.
Awesome. Great, Carol. Thank you.
Yeah, feel free to share your screen again, Leanne. Sorry.
Yep, perfect. No worries.
So the next question is from Krista. Are there any kind of guidelines? Oops, sorry. My screen's moving. Any kind of guidelines for what kind of caseload that a full-time abstractor should be able to manage, meaning number of cases per year, et cetera? So Krista, this is a great question, and I think one that has been attempted to be answered a lot. And I know for those of you at STS that we've done some, kind of data manager polls and things.
Mhm.
The hard part is not everybody only does data abstraction. And so if I said I did X number of cases per year, but you found out I also abstract for 3 other databases, or have a management position, or I run a clinic, or those kinds of things, it kind of takes away that number. Then there's programmatic differences of perhaps my hospital is the tertiary care center. We do all the transplants and single ventricles and all of that, which might be very different from one of our community partners that handles all the PDA ligations and ASD repairs. And so they're going to be able to collect data a lot faster because their cases are much less complicated, because they might send me all of their very complicated cases. And so it's really hard to come up with a number. Carol, do you have any other thoughts to that?
No, I completely agree. And also, I think you probably mentioned it, people's backgrounds and how long they've been doing it. I put the link in the chat box to take you to the data manager education page, and you'll see the different surveys on there for the 3 databases. This is usually when people ask us, what does STS recommend for FTEs? This is where I refer them to,
Okay.
because we don't have a lot of we don't provide that. It's really up to the sites and what your knowledge is, what your experience, what your knowledge is, what your experience is with abstraction, what your caseloads are, and what your other responsibilities are.
Mm-hmm.
I agree 100% with what you said.
Perfect.
Yeah,
There's
and
also the point of some have good electronic records, and I've seen people with really beautiful EHRs that have like an STS page or a PC4 database page, and then that takes away a lot of the hunting they have to do in the medical record, and then other people are going through paper charts, and so it all is very dependent on where you work.
Yeah, absolutely.
Yeah, and I have the page up with the data manager education. Can you guys hear me okay? I had to switch audio.
Yep.
Yeah.
Okay. Yeah. So yeah, I do have the page up. I know Carol put the link in there, but yeah, if you just go from the STS National Database homepage, and just scroll down, and click on Data Manager Education, here you'll find the surveys that Carol was referring to, the congenital data manager survey. And and all the slides are here that you can use to work with in terms of determining your FTEs. So it's a great, some great information. And Sydney had put these slides together, so she did a really good job. So this information is out here for you.
Great. Thank you, Leanne. And Carol. Next question. There was mention of 2 documents that should be open when abstracting. One was the training manual. I wasn't aware of the other manual. Where is it located? So I think what you hear us say is the specs and the training manual. So the data specs are what come out initially, and we take that, an exact copy of that, and call it the training manual when we provide monthly updates. So the data specs outline exactly what the definitions are, and it tells you, you know, what's a parent-child field, what are your options for answering, you know, if it says, what is your gender at birth, here are your options that you can choose from. From there, we'll get a question and have to answer it. And then we put in what's called the training manual, which is an exact copy of the data specs, but under gender, we would answer the question that we received or provide a little more clarity to the question if something is confusing. So Leanne's pointing it out here on the STS website that you see the data specs down below under additional resources, and then up above you see that training manual. The training manual gets updated every month following the core group call. So we have a core group call later today. And so in the next 2 weeks or so, you'll see that this manual will get updated here with the updates from today's call, or at least by the end of September, you'll see that it'll get updated here. And so it would just have the new updates from the questions that were answered in the core group call today.
I put that link in the chat as well, the link to that page.
Thank you.
Yep.
Thank you, Leslie. Next question from Kelly. Where do you go if the error message is not listed in the IQVIA library? Well.
It should be listed. I would need more information, like what type of error message, but all the error messages that you receive from IQVIA should be listed in that document that Carol gave you. If you're not seeing that, Kelly, if you want to reach out to myself or just let me know. But if there's a specific example you provide, that would be helpful, but they should be listed there. 500 unexpected response received.
Is that in your vendor software, Kelly, or is it in your, when you upload the data to IQVIA? Can maybe we can unmute Kelly real quick if she wants to talk?
Let me see here, Kelly.
Because the errors in IQVIA uploader should all be listed on that Excel spreadsheet, but this one, I'm not quite sure what that is.
Yeah, that might be something you have to work with IQVIA tech support directly. I'm not sure what that is, so.
Can y'all hear me?
Oh, there you are. Yeah, hi.
Hi,
y'all. So yeah, this is after I've uploaded to the IQVIA uploader, and it is showing up in my critical summary report. And I have submitted a ticket to IQVIA. I just haven't heard back yet.
Okay, what I bet what that probably is, it sounds like it could be unexpected response received. It could be an invalid value. So there may be something when the file was created, there may be like a value being received that's not valid for that particular data version. But IQVIA tech support will have to look into that. They'll have to go in the file and look and see what's causing the error. So they'll follow up with you and let you know what that is. It looks like there may be like an invalid value somewhere that they'll have to identify for you, and then you may have to work with your vendor. It sounds like that's what the issue is.
Okay, thanks so much.
No problem. Not seeing any additional questions. Let's see here. Does anyone else have anything that they wanted to add?
I know this was a lot of information thrown at you all at one time. Hopefully it filled in some gaps for those of you who've been working for a little bit and are in the throes of it all. Obviously it's not the end all be all. So if you have questions, please feel free to reach out to any of us and we'll do our best to answer, or submit an FAQ and we're happy to answer there as well.
Yep. Absolutely. If you like Chastity said, if you have any questions, please feel free to reach out to me directly. I'll add, I didn't put our contact information on this slide, so I'll add another slide with my contact information. Chastity's, Leslie. So if you need to reach out to us, but again, I'll add that to this slide deck for posting out on the website. So absolutely, please reach out to us if you have any questions at all. That's what we're here for. Please do not hesitate. There's no such thing as a dumb question. Ask any and all questions. We are here to help you and do whatever we can to make your life easier, your job easier. So just again, please use us as that's what we're here for. Oh, and Carol did put our contact information in the checkbox if you want to take a screenshot of that or just copy and paste. But again, I'll make another slide and add that before posting out on the STS webinars page. All right. Still not seeing any additional questions come in. We are coming up on the end of the hour. So I just wanted to take a moment to thank you, everyone, for joining today. We really do appreciate. We hope this webinar is helpful for you. If there's something that we didn't cover that you'd like to see in our next new data manager webinar, please feel free to share those ideas with us. Again, we want to make these useful for our new data managers. Thank you to Chastity and Leslie for presenting today. You guys are amazing. We greatly appreciate it. And thank you to my STS staff, my coworkers. Thank you guys for joining me today. I appreciate it. All right.
Great job. Good job, everybody.
So I hope you guys all have a great rest of the week. And again, please feel free to reach out for with any questions. Thanks everyone for joining. We appreciate it.
Thank you.
Guys, bye.
Bye. Thanks.